Welcome to Rubin on Point, a podcast about cancer, resilience, and being human. I'm Dr. Dan Rubin, and together we'll uncover the true power of resilience, the strength to recover, adapt, and thrive through life's toughest challenges. Each episode will bring bold ideas, transformative practices, and inspiring stories that redefine what health, healing, and what the human spirit can achieve. And you're going to meet some really cool people along the way. If you're ready to turn obstacles into opportunities and live with greater purpose and courage, you're in the right place. Let's get started. Your journey to resilience begins now. Well, hi, welcome to the Rubin on Point podcast, where we talk about cancer, we talk a lot about resilience, and we talk even more about being human. And I'm joined today by a wonderful physician who has an amazing pain to purpose story. I can't wait to hear it. I'm privileged to be holding her book. This is Dr. Jenn Simmons. Dr. Simmons, please tell us about who you are and how you got to where you are as an integrative oncologist.
Well, first, I want to thank you for having me on. It's a pleasure to be here with you today. And thank you for doing what you do, because I actually never knew what a naturopath was.
Okay.
We don't have a lot of that on the East Coast.
Mm-hmm.
And I certainly didn't know any naturopathic oncologists. So while I'm sorry I didn't during my own time and my own story, I'm so grateful to know that they exist and people like you do what you do. So thank you.
Thank you.
People ask me all the time, like, how did you get into the breast cancer space? And I want to be clear. I didn't find breast cancer. Breast cancer found me.
Indeed.
I come from a breast cancer family. We don't have the BRCA mutation, but every single woman in my family gets breast cancer, with the exception of my mother, who had colon cancer. So growing up, I had a first cousin. Her name was Linda Creed. She was a singer-songwriter in the 1970s and 1980s. She was beautiful, brilliant, larger than life, lit up every room she walked into. She was the queen of Motown sound in Philadelphia.
Wow. Okay.
She wrote 54 hits in all, and her most famous song was The Greatest Love of All.
Oh my God.
So right?
Okay.
So she wrote that song in 1977 as the title track to the movie The Greatest, starring Muhammad Ali. But it really received its acclaim in March of 1986 when Whitney Houston would release that song to the world. And at that time, it would spend 14 weeks at the top of the charts. Only my cousin Linda would never know. Because Linda died of metastatic breast cancer just 1 month after Whitney released that song.
Wow.
I was 16 years old and my hero died.
I was 16 when my mom was diagnosed. Yeah.
I mean, these are the times, right?
Yeah.
And Linda's life and ultimately her death gave birth to my life's purpose.
Wow.
And I did the only thing I knew how to do, because I never wanted another woman, another family, another community to have to suffer the way that mine suffered. And so I became a doctor, the first doctor in my family. I became a surgeon. I became the first fellowship-trained breast surgeon in Philadelphia. I became the first oncoplastic surgeon in Pennsylvania.
That's a big deal.
It's a big deal.
Yeah.
And I did that really well and for a really long time, all the while with all the writing on the walls. Because as you and I know, yes, genetic plays a part, but the reason that genetics become important is because when you continue to do the same thing over and over and over again, you get the same outcome, right? And we tend to live our lives like the people before us lived their lives.
Why did you choose surgery on top of all other specialties? And then, of course, the specialty of breast surgery. And I think oncoplasty is even a subspecialty of
It is. So I chose surgery because, first of all, this was a way that I could be specialized in the breast cancer space.
Okay.
I also happen to love problem solving, and I like to take things apart and put them back together and make them beautiful. And while my husband criticizes me all the time, he says that, we could be on easy street had you just become a plastic surgeon. And I wouldn't live this like troubled, haunted life. The truth is that I love my choice,
Mhm.
and I don't think that I am philosophically aligned with that. And we all have to do what we're philosophically aligned with. And
Yeah.
I wanted to change the world, and I knew I wasn't going to change the world by like straightening noses and tightening faces,
You're doing
right?
surgery with a different, you were doing surgery with a different type of purpose.
Yes. I mean, it was very, very, very purpose driven. And I was about 15 years into my career, long enough for my aunt to be diagnosed, long enough for my mother to be diagnosed. And I was arguably at the top of my game, running the cancer department, running the surgery department. And I'm a wife and a mother and an athlete and a philanthropist. And I have all these
Wow.
balls in the air and consider myself an expert juggler until the day that it all came crashing down for me.
Okay, hang on.
And
An expert juggler?
no, that's just a figure of speech.
Oh,
Like,
juggling a bunch of stuff.
yes, 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 yes. No, I'm not an
Type of that,
expert
what
juggler.
type of athlete are you?
Oh, I'm a tennis player.
Ooh, are you competitive?
Yeah. Yeah.
All right.
Wickedly
Wonderful.
competitive.
Yeah. How often do you play tennis?
3 days a week.
And that, how does that figure into your practice of integrative oncology? Does it help
So,
you?
for many, many years, it was how I would start my day. So I would be
Okay.
on the tennis court at 6 a.m. and then go right from tennis to work. Um, I think now I have, I mean, since I made this transition from surgery to integrative oncology,
Hmm.
I also do just about everything in my life quite differently. And I came to the realization that I am not going to Wimbledon or the French Open
Mm.
or the Australian. I'm a recreational tennis player, and I need to go out there and just have fun.
What what does the life of a specialty breast surgeon look like compared to what the life of an integrative oncologist in the world of Jenn Simmons now?
Well, unfortunately, I have more or less recreated my surgical practice in my integrative oncology practice.
In terms of
So
what?
I still work a zillion hours. I still have very little in the way of boundaries.
Hmm.
Um, but now, instead of just being one to one, now I'm one to many, right? Now I wrote a book and I have a podcast, and my day to day practice is more group oriented than it is about being one on one with people. And I'm opening these imaging centers, perfection imaging. I'm opening these imaging centers all across the country where we're safely and accurately and painlessly screening for breast cancer.
Are you using
So
QT?
I'm using QT.
Okay,
Yeah.
excellent.
And I'm pretty much the ambassador for that company. And the reason most people have heard of that technology is because I'm using it and I'm talking about it. So I think my reach is very different. My
Hmm.
messaging is very different. My approach is very different from when I was a surgeon. But my overall mission is unchanged. I
Do you
want to
miss?
change the conversation around breast cancer. I want to take away the stigma, the way that we approach it, the death sentence, the fear, the pain, and I'm changing all of that. I'm changing how we diagnose it. I'm changing how we treat it. I'm changing how we screen for it. And I'm changing how life is after. Because the title of my next book is
Hmm.
called The Forgotten Woman. And it's that woman who has been diagnosed with and treated for breast cancer and told that she should be grateful to be alive. And she is grateful. But it's very hard to feel grateful when you can't sleep and you're anxious and you're depressed and you can't
Mhm.
remember why you walked in the room and you have palpitations and you have dizziness, you've gained weight, your breasts are deformed or absent, your weight has redistributed, your clothes don't fit, your bones ache, your joints ache, your skin, your hair, your nails, everything is dry. You have no libido, sex is unwanted or painful, your relationship is suffering or absent. It's hard to feel grateful when all of this is happening. And yet, this is how we leave most women after breast cancer treatment.
Well,
And it is because these are things that are mostly caused by the way that we treat breast cancer. We either put people into early menopause or we exacerbate the symptoms of menopause. And we are very short-sighted. I mean, when we talk
mhm.
about survival, we talk about 5 years. Tell a 38-year-old how meaningful a 5-year survival is, right? It's
Yeah.
nothing.
Oh, no, right. Absolutely. I mean,
It's
5 years,
nothing. It's disgraceful. And yet we celebrate ourselves that we've gotten them through 5 years. And yes, I mean, maybe we have gotten them through 5 years, although I would argue that that is not meaningful. Even that landmark is not meaningful. But that, what are we leaving them with? How are we leaving them?
well, I think
How
it
are
says,
we
how are we? I'm sorry, keep going.
No, I'm saying, like, what kind of life are we really creating for them? And beyond that, we are actually creating disease. We are leaving these people way worse off than how they started. So they're 2 to 3 times more likely to die of cardiovascular disease than women who are not treated for breast cancer. They have increased risk of neurodegenerative disease. They have increased risk of osteoporosis. And let's us not forget, women die of a complication of a fracture at the same rate every year as they do of breast cancer. So if we're going to solve one problem, we can't do it at the expense of creating three others.
Absolutely. And those diagnoses are sometimes on top of the cognitive aspects or the mental, emotional, spiritual issues that these
Yes, of
women are facing
course.
too with the list that you just talked about, which your new book sounds to me that there's an underlying philosophy, which really for this podcast, because we talk about cancer, we talk about resilience, which is these women who just have no choice but to be resilient and move through it. I mean, they can't go around it to some extent. They're going
Yes,
through it. And
that's
it sounds like
true.
you may be showing us a way that maybe going through it doesn't have to be as tough. But at the end of the day,
Yes,
the forgotten woman sounds to me like that's the utter humanity of that female, of that woman. And that's the part that's not, it sounds like you're not talking about one individual woman that was forgotten. It was the femalality, that which drives them and creates their femininity for women that have breast cancer. I'm thinking especially those with
exactly.
estrogen receptor positive breast cancer. Can't wait till it comes
Exactly.
out.
Yeah.
Yeah.
We forgot about the woman inside
Well, it
inside
sounds
of
like
that
the
person.
conversation that oh, yes, it sounds like the conversation that you're changing has got to start with screening.
For sure, without question.
How
And
should
that's
women be
important for
screened?
two reasons.
Okay.
So I do want to talk about how women should be screening, but I want to talk about why this conversation is so important. When you use a very unsophisticated tool like mammogram to
Hmm.
screen, you do two things. First of all, you lead to a lot of um, false positives. You lead to a lot of unnecessary studies, unnecessary biopsies. 80% of the biopsies that we do in this country are for benign changes in the breast. 80%, right?
80%.
So we are over biopsying people,
And that's
which,
from a
not for
surgeon's
nothing,
point of view, too.
yes, that's
Yeah,
from a
I mean,
surgeon's point of view.
yeah.
So, not for nothing, once you biopsy a woman, you can't unring that bell for her. She forever feels like she's abnormal, her breast is abnormal, she's at high risk, right? Like it's a problem. Beyond that, when you're using a test that causes cancer to screen for cancer, you're going to cause more cancers.
Mm.
And every mammogram you have in your lifetime increases your risk of getting cancer.
That's
Every single one. And
okay.
now I am not saying that one mammogram causes cancer. Like I please know that I'm not saying that. But most women don't get one mammogram. And obviously, there's going to be that story of, oh, well, they found my cancer on my first mammogram. Okay, so your cancer was caused by something else. But talk to the 60-year-old who's been getting mammograms every year for 20 years.
Hmm.
It's very likely that her cancer was caused by mammogram because that radiation just adds up year after year after year after year. So we are causing a certain amount of cancers by using mammogram to screen because we're using a test that causes cancer to screen for cancer.
Because it's
And when,
radiation.
because it's
It-
radiation.
And the breast is put in sort of a confined position and not
Well,
let
it's compressed to
compress.
like an inch of its life.
Yeah.
And so
Yeah.
we're causing direct trauma to the
Yeah.
breast and then radiating it
Yeah.
at the time that we are inducing trauma.
It's like burning a sunburn.
Yes. And listen, I don't it's not about the pain for me. So for all those people that are going to come back at me and say, "Oh, my mammogram wasn't that bad." Like good for you if you can tolerate that pain. But this was never about pain for me because
Hmm.
like women are super tough. I mean, we give birth to children. Like we can handle pain. If
Here,
pain were a
here.
problem for us, the population would end, right? It's
Yeah.
not
Okay.
about
Good
pain.
point.
But we tolerate a lot when it's for the good. When you give birth, you get that beautiful child, right? You get a tremendous reward for all of that pain. But we're not getting rewarded for getting mammograms. In fact, it's quite the opposite. And we have known since 1977 that mammograms do not save lives. Now, I know that's heresy, and I know it's against everything that anyone has ever said and anyone has ever heard. But the bottom line is that mammograms do not save lives. And you don't have to take my word for it. We have tremendous, huge population based studies that prove that not only do mammograms not save lives, but when you use mammogram to screen, you are overdiagnosing cancer by somewhere between 20 to 30% of the time.
Now,
That
when
means,
I'm sorry, when you say that mammograms don't save lives, you're talking in general, big population studies. You're not talking about the individual woman who, like you just gave that example, just for our listeners.
yeah. So, I mean, it's questionable. And even Otis Brawley, the
Mm.
former head of the American Cancer Society, said that the benefits of mammogram have been overstated. And when we talk about overdiagnosis and acknowledge the existence of overdiagnosis because it's very real and it's there, it means that not only were women not helped by mammogram, but many were harmed by mammogram. And when you look at the statistics, when you look at the population statistics and you look at screening 2,000 women
Hmm.
over 10 years, you will maybe save one life and you will cause 10 to 20 women to be unnecessarily diagnosed and treated for breast cancer.
That's a complex statement because some people would be like, "What do you mean unnecessarily treated for breast
Yeah.
cancer?"
So I mean that this the findings in that breast on that mammogram
Hmm.
would have never become clinical disease because we all make cancer cells, right? The very young, the very old,
Hmm.
everyone in between, we all make cancer cells, but our body has a built-in defense mechanism that recognizes those cancer cells in their infancy. And so, not all cancer cells will form a tumor. Not all tumors will go on to become life threatening.
Got
And
it.
I'm not even talking about DCIS. I'm not talking about that non-invasive entity. I'm talking about people who have microscopic findings that are then getting biopsied and given that label that they have breast cancer and put through breast cancer treatment, which is not benign. Breast cancer treatment
Sure.
causes all of those things that we talked about. And it's
Yeah.
very, very serious because we are affecting both the quality and the quantity of that woman's life when we give her that assignment and treat her for breast cancer. So, when we look at the Swedish studies, 600,000 women,
Mm-hmm.
and we divide them into women who are screened with mammogram, women who are not screened with mammogram, because it is universal health care there. They all have the same access to care. They all have the same kind of care there. The same exact number of women die of breast cancer in each group. There's no survival advantage. The only
Interesting.
difference is 20 to 30% increase in the number of cancers diagnosed in the women that screen for breast cancer. So if we're not saving lives, what are we doing? It
Well,
doesn't make any sense
yeah, that
unless we're
might be a
saving
different
lives.
discussion.
And this same exact data was reproduced in the Canadian breast cancer screening study. Same thing, 90,000 women, 45,000 were screened with mammogram, 45,000 underwent physical examination. The same exact results. The same number of women die of breast cancer in each group. And
Mm-hmm.
the only difference is that we diagnose 20 to 30% more breast cancers in the group that screens with mammogram as opposed to the group that doesn't.
Well,
So if we're not saving lives and physical exam is doing just as much, and we only have a delta of about 5 millimeters between what mammogram can pick up and what physical examination, a well-done physical examination can pick up, what are we doing? Why aren't we training our practitioners? Why aren't we training our ladies to examine themselves? Right?
I agree. I mean, this
So
is a motif clearly in America in terms of health, and I mean, there's a lot of mammogram centers out there.
there's a lot because
Yep.
they make a lot of money for the system, a lot. And imagine if overnight we were treating 30% less breast cancers. Imagine if overnight we were doing even, let's not say 80%, but 50% less biopsies, right?
Mm-hmm.
It's going to have a significant financial impact on the system. But you know who it helps? The women.
Mm.
It helps the women
In a
because we
way,
don't need unnecessary biopsies. We don't need to be overdiagnosed, and we for sure don't need to be overtreated.
I mean, in a way, it sounds like they've been forgotten in the name of overdiagnosing.
Of course they have. Of course they have. And these are the women that are hurt the most
Mm-hmm.
because they're treated absolutely unnecessarily for breast cancer, and their lives are, I hate to say it, ruined.
So should nobody, in your opinion, get mammography, or just some people?
Never for screening. Never for screening. So this is what I do for screening, and it applies to everyone.
Okay.
Everyone needs to be doing self-breast examination. No one is ever going to know you better than you know yourself.
Yep.
Every single woman, newsflash, every single woman thinks her breasts are lumpy. It's okay. Own your lumps. Know
Okay.
what they feel like when they're normal so you can know what they feel like when something changes. Then I use the ARIA test for screening. It's ARIA, AURIA.care. And if you use my code, Dr. Jenn 20, DRJENN 20, it is a very, very affordable test.
Okay.
This is a test where we're looking at the fluid in the eye. So you put a little piece of litmus paper in your eye and then you send it off to this company. And we're looking for these specific inflammatory proteins that are present in the very early stages of breast cancer. So the S100A8 and S100A9 proteins.
Fair enough.
And if you have the presence of these proteins, we know that you are either at risk for breast cancer or you have breast cancer, right? So
Mm-hmm.
if you have a low risk result, then you don't even need imaging. Physical examination and this test suffice. If you have a clinically significant result, then you need imaging. And the imaging that I recommend is either QT, if you have access to QT, and my
Hmm.
perfection imaging centers right now are in Pennsylvania and California, and I will have perfection imaging centers in New York, in Florida, in Texas, in Massachusetts, um, in Atlanta, and in Tennessee within the next year.
We've been using QT out here. One of my colleagues, Dr. Shukla out here, has had a QT for a few years. And
Yes,
I
yes,
know
she
Dr.
has.
Stills is, okay, and then Dr.
Yeah, and
Stills is
Dr.
putting one.
Stills is putting one in
Yeah,
her clinic. Yeah,
excellent.
absolutely. So you're very lucky to have one in the Arizona area, in the
Mm.
Scottsdale area. Um, a lot of people are not so lucky. People are traveling far and wide to come to my center in Philadelphia, of which, I'm so, so, so grateful. And I have made it my life's mission to make sure that every woman who wants access to this test gets access to this test. In the meantime, if you don't have access and you don't have the luxury of travel, then you can do an ultrasound. Now, most of the time, the problem is that the providers say, well, we won't do an ultrasound without a mammogram, or we won't cover it. I I tell people that if you if you are in the screening population, right, that means that you are asymptomatic, you have no reason to believe that you have breast cancer. There is no way that you should be exposing yourself to the harms of radiation, right? If you are in the screening population, absolutely not. If you're in the diagnostic population, if you have a mass, if you have any change, if you have a reason to believe that you might have breast cancer, this is a different story. We still need to use diagnostic mammograms because it's the only language that the general medical population speaks, right?
Hmm.
So, and anyone who comes to me for a scan, if they have an abnormal scan, I send them for these diagnostic studies. I send them for a mammogram. I understand no one wants to have a mammogram. I understand that they come to me because they don't want a mammogram. I get it. I don't want a mammogram either, right? But the truth is that the world hasn't evolved enough to skip it yet. Yet. Like, give me 5 years. I'm
Yep.
going to solve this problem, I promise.
Hmm.
But for now, we're kind of stuck in that limbo place. So if you need a diagnostic study,
Hmm.
you may need a mammogram. If you are screening and you're trying to screen with ultrasound and your doctor is insisting that you need a mammogram, offer to sign a release. Offer to hold them harmless. Say that you understand that there are things that mammogram picks up that ultrasound won't, and you won't hold them responsible for that. Try to appeal to their sense of humanity. The problem is that they've been brainwashed, right? Like the critical thinking has gone out the door, and they're so conditioned to believing that mammograms are safe. And they say ridiculous things like, well, it's the same amount of radiation that you would get on a cross country flight. And you don't tell people not to fly cross country, do you? And it's like a ridiculous, ridiculous argument because anyone can appreciate that there is a vast difference between the scattered radiation that you get on a flight, which is capable of very little damage, and the focused, coned down radiation that you get to the vulnerable tissues of the breast during a mammogram. And anyone who can't see or understand that logic, think of the difference between the sun, which is arguably the greatest collection of energy there is. But by the time the rays get to the earth, they're so scattered that the worst that you could ever get is a sunburn, right?
Hmm.
Whereas think of a laser and the
Yeah.
fraction of energy that a laser contains, and yet a laser is able to cut through glass and rock, right? When we
Hmm.
focus it down, it is capable of great damage and destruction. And that's what's happening during a mammogram. So I I fully believe that we should take advantage of all of our medical advancements and technologies. And at the same time, I think we need to be able to protect our people. And I think that medical sovereignty is important. We should be able to decide. We should have a choice. And your doctor believing that mammograms are safe because that's what they've been told and that's the, like they are often guilty of saying, oh, well, it's the same radiation as a cross country flight. Like they're not thinking because they're not capable of thinking anymore because it's been so drilled into them that
Hmm.
mammograms save lives and it's only this amount of radiation. And they don't think about how it's delivered or whether or not that statement is actually true. So I would just say that, try to appeal to their sense of humanity. And it may work, it may not work. You may have to shop around a little bit. And hopefully, this will all be a moot point in a couple of years because I am forever changing the way that we screen for breast cancer.
Thank you for changing the conversation. I do have to bring one more tidbit into this conversation since we're talking about screening. And I think probably both of us have a patient population that may ask, well, what about thermography?
Yeah, so thermography is a wonderful test to look for inflammation. It detects a heat signal. I do not use it as a screening tool for breast cancer because I don't think it's a reliable screening tool for breast cancer. Many breast cancers are very, very, very slow growing. Now, I could also argue that maybe those are the ones that don't need to be detected. But slow growing cancers will not generate a heat signal and will not get picked up on that imaging.
Yeah, great. Yeah, I'm not an advocate for thermography in general, but I understand it's a tool for inflammation, but I don't really know where it fits in. This has
Yeah,
been
so
great.
for me, I use it in the woman who's been diagnosed and I do whole body thermography
Mhm.
because where are the offenders hiding? Like, do they have inflammation in their mouth? Do they have inflammation in their gut? What am I missing? Right. And
Mhm.
so I use it for those purposes, but I do not use it as a screening tool for cancer because it is not a screening tool for cancer.
So important. You know, here we are. We're talking about screening, and I know there's other big issues that you discuss in your book and that you have expert knowledge on. And one of those certainly is, does estrogen cause cancer? And
Yeah.
specifically estrogen receptor positive breast cancer.
Yeah.
Is that something that we can talk about for a few
Yeah,
minutes?
for sure. Absolutely. I mean, you know, this is all part of a very convenient narrative, right? Like,
Mm.
if we can convince people that estrogen causes cancer, then we can sell them drugs to block estrogen as the treatment, right? And the problem is that estrogen not only does not cause cancer, but estrogen can also be used as a treatment for cancer. But the problem is that we cannot trademark a molecule of nature.
Mm.
So there's no way for the pharmaceutical companies to make money off of hormone replacement or bioidentical hormone replacement or estrogen therapy. There's no way for them to make money off of it if you were talking about bioidentical. So what do? They villainize it. And we've seen this story play out over and over and over again, right? What did we do? We villainized cholesterol to sell lipid lowering drugs and cause diabetes.
Mm.
We we continue to villainize the sun for the purposes of selling sunscreen. And what happened? We have unbelievable levels of vitamin D deficiency, and cancer rates have only increased, including skin cancer, right? So this is just another narrative for the pharmaceutical companies. Listen, if estrogen caused breast cancer, then that would mean that every woman were put on earth for the purposes of developing breast cancer. If estrogen caused breast cancer, why don't we see it during the times when women are estrogen rich? Why don't we see it in teenagers, 20-year-olds? Why don't we see it during pregnancy when our estrogen levels are 10 times higher? Why do we see the bulk, the preponderance of hormone positive breast cancer in postmenopausal women, which anyone who works with postmenopausal women knows her estrogen levels are barely measurable, barely measurable. And quite frankly, when we look at the subsets, women who have increased weight, they're overweight, they're obese, they have elevated levels of estrogen. And yet, being overweight or obese in the premenopausal population, when you already have more estrogen as compared to the postmenopausal population, it's protective. We
I mean,
see less breast cancers in that group because estrogen is protective. Estrogen is protective.
one may argue, Dr. Simmons, that those patients who are so estrogen rich in their younger years, maybe their immune system is stronger, maybe their cells don't have as much sort of biological garbage associated with them, and they're able to subdue a breast cancer, or maybe, the type of breast cancer that maybe estrogen did help in the development of actually wasn't mutated enough so that it was able to survive, or maybe the immune system did take care of it, or maybe when they were so estrogen rich that they actually had development of a breast cancer, but it was so slow growing and then it shows up later in their years. I know there's people out there who would argue that point with you, but you're saying that
Yeah,
estrogen.
this would be an argument that they won't win. Because what's happening is that when we look at normal breast cells, they have estrogen and progesterone receptors on them, right?
Okay.
This
Yep.
is the way that normal breast cells know how to behave. This is how they interact with our hormones. This is how cell signaling works. This is how they know when to proliferate and when not to proliferate. So it is normal to have estrogen and progesterone receptors on your cell surface. So when we talk about breast cancers that are estrogen positive and progesterone positive,
Hmm.
this is a variation of normal. And it's only when the cells become hormone negative that is a far cry from normal. That is a departure from normal, a mutation that they can no longer listen to the normal signaling, and they can no longer be manipulated with the normal signaling. So um, I I actually think that it's a good thing when we see hormone positive disease, because that means that they are maintaining some of the normal characteristics of a breast cell. And for many years, before we were so driven by what the pharmaceutical industry says, we used estriol for the treatment of breast cancer. We used progesterone for the treatment of breast cancer because they're anti-proliferative. And it is only since this pharmaceutical craze that we've changed our narrative and are doing things differently. But remember, tamoxifen, which is one of the most widely used, studied, and prescribed drugs for breast cancer and breast cancer prevention, this is a synthetic estrogen. That's what it is.
Yeah.
It's a synthetic estrogen. And the reason that it's carcinogenic is because it's not bioidentical. So we don't always do the right thing with it, depending on where it's landing, depending on where it's attaching. So it looks like estrogen and sits on the estrogen receptor. And it turns out in the breast, it is protective, but in the uterus, not so much. In the uterus, it's proliferative. And there are lots of women who get into trouble with tamoxifen because it increases the uterine lining proliferation and they get uterine cancer.
Well, it's interesting too, because we'll measure some women's even high sensitivity estradiol levels, and we always are measuring estrone and estrone sulfate in women with estrogen positive breast cancer. And some women who are on tamoxifen, their levels will be astronomically elevated. So either there's so much tamoxifen in their system and it's being read by the lab analyte machine as estradiol, or their body is really saying something to them and saying, hey, what are you doing to me? Because I'm trying to treat myself. This is the healing power of nature speaking, and tamoxifen is blocking it for them. So
Yeah.
I think it's interesting. We have a program here, and we have for we're going on 19 years now, I believe, where we opened up a program to help people with estrogen receptor positive breast cancer who have declined tamoxifen or aromatase inhibitors or something in that area. And I think that would be a wonderful discussion for us to have on another podcast, if I may invite you
Yeah,
back.
I would love that.
Thank
I would
you.
absolutely love that because I think that people need alternatives and they need safe alternatives and they need natural alternatives. But most importantly, I mean,
They need education.
Yeah, they do.
Mhm.
And this is largely why I wrote my book.
Yeah,
So
you're
that
here.
women actually had the opportunity to make educated decisions about their diagnosis, about their treatment, and about how they were going to move past this. Because as you very well know, everyone who gets a breast cancer diagnosis gets a treatment plan. But what everyone needs is a health plan. And nowhere
Yeah.
in our conventional medical system is anyone getting healthier. And in fact, they're actually left much worse than
Yeah.
how they started. And nowhere is this better demonstrated than in the aromatase inhibitor population. I mean, these women are miserable, absolutely miserable, so much so that they often just stop taking the drug and don't tell their doctors.
Yeah. And then they tell us.
Yes,
Yeah.
exactly.
Yeah.
Or they want to know, like, how do they approach it with their doctor? Because they just keep collecting prescriptions.
Yeah. Fascinating subject. I really, Dr. Jenn Simmons, thank you for being a champion for women and changing this discussion and changing the world, and everything that you've told us here and with what you're doing and opening up your centers. I can't wait to learn more about. And I really would love to have part 2 of this discussion on the treatment and talking more about estrogen, because there's a lot there and you have an expert opinion on it. Thank you.
Yeah, let's do it.
Okay. Thank you.
Thank you for having me. Bye.
Bye.
Thank you for joining us on Rubin on Point, a podcast about cancer, resilience, and most of all, about being human. I hope today's conversation inspired you to see new possibilities for growth, healing, and strength in your life. If you enjoyed this episode, be sure to subscribe, leave a review, and share it with someone who could use a little extra resilience in their day. Remember, no matter what challenges you're facing, resilience isn't just about bouncing back. It's about building a life of purpose, connection, and vitality. Until next time, stay strong, stay healthy, and take care of yourself.